So this is the VC. So the moment you say OLR, that's the lunate direction. Okay? So it's less than 30 degrees. So as I said, these two terminologies postgraduates hate, but then if you understand these basic things, it becomes much easier for us to understand this, right? So these are all involving the proximal row, basically between the ligaments, and that's why it's called as the carpal instability dissociative. That is the terminology in the classification, but to understand the terminology, you should understand right from normal X-ray to all these things. Okay, and the lunate is the most important key bone in the entire carpus for our instability kind of understanding. Scaphoid is a bone which spans both the rows, strong bone, but lunate is a key bone in terms of stability itself. Very, very important. Video please. If you look at your daily practice, most of the time you see these in distal radius, right? And they're all moving separately now. So a lot of times we fix the distal radius with beautiful plates, the best of the plates. Patient keeps coming back with pain. Right? We tell no, it's healing, that is okay, plate looks okay. But what has happened here in this patient is this: the scapholunate joint has become unstable there. And that is the problem with it. So very commonly you have to check, especially with your distal radius fractures, because the injury might not be limited to just distal radius when somebody falls. It has to damage a lot of soft tissues. Right? And that is what happens here. Okay, so you need to reduce that. Once you fix the distal radius, you have to screen your carpus always and see what is happening there. So the best way to reduce that would be take the lunate, make sure it is in the center. So you put a radiolunate wire temporarily there, keep it in the neutral position, and then fix the scapholunate joint. If you try to fix the scapholunate by K-wire, your K-wire keeps pushing the lunate away. So always fix the lunate first into the neutral position, and then fix the scapholunate joint, right? That way, and scaphoid has a tendency to flex, so you put another wire from scaphoid to the capitate, scaphocapitate wire like this, okay? Video. So now the whole thing moves very nicely, okay? That's what we want at the end of the day. The whole thing, carpus moves synchronously. Other video, right? And we want those movements back for the patient, and this is what will give you a painless. Your distal radius is fixed nicely, but otherwise the carpus injury should be taken care of always. Now, if the force progresses, all this happens, as I said, scapholunate is the most common carpal instability pattern, but if the force increases, it moves, then what happens? So this group, Mayfield, from the Mayo group, and sadly his picture is cut off in this. And so he was Mayfield. They did this beautiful experiment, a cadaveric experiment. This is the paper, 32 cadavers they loaded more on the radial side, and they saw what happened. Right? This came out in 1980, and our entire understanding of carpal instabilities became much more clearer there. So people knew much more about what happens clinically, but they were not correlating with anatomy and mechanics. So they conducted this study, and they thought the postulation was that on a outstretched arm, if somebody falls, there will be a lot of hyperextension, ulnar deviation, and what is called as the intercarpal supination, and the sequential ligament ruptures would then lead to dislocation. So they loaded 32 cadavers, and then they had this, one was slow loading and one was fast loading. Very interesting kind of experiment. And all these were, senior radiography was done, X-rays were done, and they saw it actually happened. Sequentially, each of these ligaments started, getting damaged as the load increased, and finally the entire load came down for a complete instability. So this is how the progression happens in carpal instability. Okay, this is called as Mayfield's progressive perilunar instability. The force goes from scaphoid here, capital lunate, lunar triquetral, and comes back like this, right? And that is why we get other kind of injuries, which I'll come to that later. So another case here, second case, high energy injury. Okay, same checklist. It's a PA view. The lunate now shape is triangular. The Gillas arch is broken here. We know there's a problem here, right? And the lateral view shows a story there, different story. Now that the capitate is not in line with the lunate. Capitate is completely gone back here. That axis is changed, right? So there is a dislocation here between the capitate and the lunate, right? and it's gone dorsally here. This is the classical perilunate dislocation. This is the next level of carpal instability, which is very, very often missed. Almost 25 to 30% is missed initially, and this is a perilunate kind of dislocation. What happened there? All the injuries, the ligaments got damaged, scapholunate, capitolunate, lunatotriquetral. All these got damaged, and these are called as lesser arc injuries because only ligaments are damaged. If it's a greater arc, it is actually with the fracture. Okay? So perilunate injuries is not an isolated injury. It always starts with scapholunate, and then it goes on to become a very severe injury like this. Okay? Another case, if you look at this, again same checklist, PA view, Gilva's arcs are broken, the lunate looks triangular. There is also something else here. Apart from this,
Professor has a vast experience in hand, and we requested him to stay for this conference. He kindly consented. He was there in the workshop yesterday, training the tendon repairs. And today and tomorrow also he is going to stay. Thank you, sir. So in this context, our student Gopinath Bhandari is our KMC student, Karthik Mehta student. He is a student of SAR also, Kasturi Medical College. So KMC, both become. So we like to express his gratitude for the sir.
Thank you, sir. First of all, I would like to thank the organizers and Ramkumar Reddy sir for giving me this opportunity. Yesterday I could conduct a workshop, and a lot of about 40-45 PGs to take the benefit of having a live tendon, live hands-on session, and also Ramkumar Reddy sir could give impromptu this thing so that we could award 3 teams by a good whoever has done a good repair. And second thing is I would like to take this opportunity to thank Anil sir for being with us for 3 days, and also at the same time there is a book called Cases, which is written by Anil sir, which is very much helpful for all the postgraduates. I urge everybody to know about this book, and also if possible it is good for all the postgraduates for their examination purposes. Thank you, sir.
I request Dr. C. Raghuram sir to present certificate to Dr.
Ashok sir and the students.
I request Dr. Ramkumar sir to honor Dr. G. Krishnamurthy sir. I request Dr. Ramkumar Reddy sir to honor Dr. C. Raghuram sir.
Ramurthy.
I request Dr. Session to come onto the stage. Dr. R. Selvaraj sir, Dr. C. Hariprasad Rao sir, Dr. P. Kalprasad Rao sir. Please come onto the dance.
At the outset, I would like to thank the organizers of the August conference here. And good morning to everyone. In this symposium on trauma, I am talking about medial condyle fracture of the proximal tibia. I have the only. Yes. But when it comes to the medial condyle fracture, amongst these fractures, they get even rare. Isolated medial condyle fractures are very rare. If you see here, the upper three fractures, 1, 2, 3, they are all lateral condyle fractures. Whereas the lower three, they are complex fractures. Type 4 is a medial condyle fracture, and 5 and 6 are bicondylar fractures, wherein again medial condyles are also involved. And the other picture actually shows the equator of the proximal tibial articular surface, which extends from the attachment of the lateral collateral ligament anterior part to the posterior part of the medial collateral ligament. And anything anterior to it is considered as anterior, anything posterior to it is considered as posterior. In fact, because these fractures are not including so many other varieties, Schatzker himself has modified his classification using the equator into anterior and posterior variety in each of those. The other important classification one should know about is the three-column classification published by Luke. Basically, if you see the long bone of the tibia, it has got a lateral cortex, it has got an anteromedial cortex, and a posterior cortex. Basically, these are the three pillars, and these are supporting the upper surface or the proximal tibial articular surface. The lateral condyle is mostly connected with the lateral cortex and the posterior cortex. And medial condyle is connected with the medial anteromedial cortex and the posterior cortex. So here, again, lines are drawn just like what I was telling you, from the anterior part of the fibula to the posterior part of the medial collateral ligament, the center. And when you draw all the three lines, you can find the red one is the medial condyle, blue one is the lateral condyle, and the posterior column. Medial column, lateral column, and the posterior column. And medial condyle fractures basically involve the medial column and also the posterior column. In the Schatzker group, the type 4 are the medial condyle fracture. These are often associated with dislocations. And critical issues like vascular injuries, ligament injuries, dislocations, all these are much higher in this group of injuries, and so they have a worse prognosis compared to other fractures. These type 4 fractures are further classified by Walquist into three types. The fracture line goes basically from the anteromedial surface into the articular area. If it goes into the medial condyle itself, it is type 1. If it goes into the intercondylar area, it's type 2. But when it crosses the intercondylar area and goes into the lateral condyle, that means it's much more unstable injury. So that is type 3. And these type 3 injuries are having the worst prognosis. As seen in this study, they have shown that the type C, 6 out of the 9 cases presented in this series have compartment syndrome. One of them has a tibial artery and a peroneal nerve injury also. So these are a significant injuries. Similarly, when it involves the medial and the posterior column, the posterior and medial and posterior injuries, two column fracture, highest incidence of dislocation of the knee is noted. How to evaluate this? Simple, plain X-rays, mostly give very good information, and you need to take a tibial plate tube which is taken at 10 degrees caudal so that you can see the articular surfaces properly, as the plate tube has a 10 degrees angle. Now, CT scan gives very good information because it gives us a three-dimensional orientation and also gives the coronal and the sagittal and the axial section, so you can actually do a three-dimensional reconstruction of the fracture before we undertake the surgery, so that we can plan. Now, MRI also has a role, particularly in these injuries, because as I told you, they have more and more soft tissue injuries. For example, in this MRI, here you can see the arrow is marked at the lateral meniscus, which is torn and is actually impacted into the fracture gap. And if you try to do a closed reduction in this case, only from the medial side, opening only from medial side, the meniscus will not allow the reduction of the lateral condyle, and you may have to open on the lateral side also. The goals of treatment are basically restore the alignment, the anatomy, to get a stable knee with an articular congruence to get normal function. Indications for any intra-articular fractures are similar, very minimal, up to more than 2 millimeters of displacement in the articular step, or significant angulation or displacement in open fractures. Now, amongst the tibial plateau fractures, presence of a medial condyle fracture is more or less always an indication for surgery. Timing of these injuries and surgery is very important, because as I told you, these patients will have a lot of soft tissue injuries, edema, compartment syndrome, and on day 2 you might find a few blebs, but by day 3, day 4, the entire limb will be filled with blebs, and you will have blisters, and you will have to postpone the surgery maybe 1 or 2 weeks till these heal and all the edema subsides, then you get what is called as a wrinkle sign. In the tibial condyle fractures, as I was telling you, presence of a medial condyle fracture or a posterior medial condyle fracture is an indication for surgery, because if you see here, the posterior medial condyle is basically a shear fracture. The fracture line is more vertical, and so it is unstable. So it is always prone for instability, even if the lateral condyle is fixed. And similarly, the incidence of in the bicondylar fracture, almost 50% will have posterior medial fragment, and it involves around 25% of the articular surface. So the incidence of instability with the presence of this fracture is very high, so it always requires surgical fixation. And even if it is not displaced much,
tibial condyle fixation techniques by Srinivas Kasha. I request all the speakers to stick to the time, please.
Thank you, sir, for opportunity given and their classification. I am dealing with posterolateral condyle fractures of tibia, fixation techniques. A 20-year-old male presented with this particular picture to me, that is operated around 2 years back, and when I go back, so it was a coronal fracture which was fixed with a screw, and that obviously collapsed and then landed up in arthritis in a 20-year-old. So having a proper concept, let me actually take you through the steps of lateral condyle fixation principles. So here is a 24-year-old male. I have treated in around 2008. You got a significant lateral condyle depression fracture. If you can see, there is a posterior spike on the lateral view, and so that's been elevated, and have put an anterior posterior screw to hold that, whatever trap door that is there. And that's the post-operative picture, which seems to be okay because I have grafted it. And after 2 years of time, we started to have pain, and if you can see, there is a collapse on the lateral condyle. This is what exactly happens even if you put a screw from anterior to posterior, because you need to buttress it from posteriorly so that this coronal component of fractures won't collapse. So that's the area he actually has a pain, and that is the collapse which has happened. So that's where this concept comes, which is been nicely illustrated by Harsharma sir. And your buttress plate should be on the posterolateral and posteromedial whenever there is a coronal component. So Just an example, if you see an AP view, it's almost normal kind of an injury, but if you see a lateral view, you can see a coronal fracture in this case. And these coronal fractures are axial loading fractures which happen in flexion. And that causes a shear force, something like that. And all these fractures get reduced only in extension, something like that. Because you have got an intact capsule, so as long as it is in flexion, it is difficult to reduce. So, and mediolateral fixation in these cases won't address the shear forces because your shear forces are posterolateral and posteromedial side, and it further collapses, something like that. So what you need to have is a buttress from the posterior side, which actually counteracts your axial forces, shearing forces into compression forces. That's exactly the principle of buttress plate, and that has to be done in posterior, medial, and posterolateral. So, what are the approaches? The critical thing is to approach this critical area. That's just an example of posteromedial. And these are the approaches which are available for posteromedial as well as posterolateral, which are mainly described around 2010. Lobenhoffer's approach, Carlson's, Frost and Solomon transfibular approach, and Luo 3-column theory, all of them are around 2010, and these three can address your posterolateral component. And the first thing is Frost approach. This is without fibular osteotomy, the incision being on the fibula, and should be a long incision onto the femur as well. And you have got two windows, one from behind the biceps femoris. The second thing is over the back of your posterior to your fibula, where your soleus has to be elevated, and you get a clear zone where you can put a small plate or a scoop. So this particular technique has to be done within a short length from the condyle, which should be around 5 centimeter distal, not beyond that. Because
it's again nostalgic for me to be in front of my own fraternity, my professors, associates, and assistant professors. So change is inevitable, and you will not be the same. When we are started as a PG, and now where I stand, it's a big growth. It all depends on how deep your roots are. I'm thankful for all my fraternity here. I know this talk is completely outstanding from the pack of talks, and it is a very specialized talk as well. Articular cartilage damage in sports injuries is very overlooked in component, particularly in knee injuries or in sports injuries of the knee. So, can you put up the talk, please? Associates and assistants, and feels a great moment here. After coming over here, I can see all my seniors as well. Maybe I missed a lot of juniors here. At the moment, I'm working in AAG Hospitals, Gachibowli. I'm the director and head and chief of trauma unit there. I relocated from UK and years after spending almost 18 years of life there. And it's been around 4 years now in Hyderabad. That's not my fault. I wish I can go there. Sports injury, a mystery for the unknown. So why is knee joint more prone to injury? For the next slide, please. Static and dynamic constraints, but the shallowness of the static constraints and the articular surface makes it more prone to injuries, particularly in the pivoting movement and rotational movements. So it also has high degree of movement. We think that it's only a hinge joint, there's not much of movement, but it can undergo a distraction, rotation, pivoting, etc. in this epidemiological study to know how common is knee injury. Almost 68% of men are injured when they are around 20 to 29 years of age, and 38% of women are injured. And among all the intraarticular structures damaged, ACL, meniscus, and the condyle injuries are very common. Most of the condyle defects that are seen are occurred in athletes, almost 40% of them. Among them, almost full thickness defects are seen in 36%, which is overlooking in most of the cases. And the patellofemoral joint, followed by the medial femoral condyle, and the medial tibia is the more common locations where you see condyle defects. When you look at the sport-specific injuries, it is more common in soccer, followed by basketball, and then the skiing injuries. And it will be interesting to know how much is it common in cricket players. It is only 2%. I think sports surgeons has to encourage people to play more soccer to get their practice up. When you look at the natural history of cartilage damage, what happens once a condyle defect is there and if it gone unlooked? Most of them, if you look at grade 1 and grade 2 cartilage changes, they usually has similar outcomes compared to whether you do anything or not. When it comes to grade 3 and 4 injuries, they are the ones which need some intervention. And it is very well demonstrated by Shelburne and Grotterud in their long-term studies, particularly the Norway and Swedish knee ligament injury registry has given enormous data which directs you in how to deal with these injuries. Clinical diagnosis, it mainly depends on mechanism of injury, and you need to have a high degree of suspicion to understand why and when this can happen. Particularly, you have to look at the patellofemoral joint as well as the medial femoral condyle for these injuries. The diagnostic additives, in them, the X-ray has no role in identifying condyle injuries. The gold standard is still an MRI. 3 Tesla MRI is the best in imaging, and ultrasound scan, aspiration, etc. has no role in diagnosing these lesions. When it comes to MRI, the specific protocols used in diagnosing these lesions, particularly the gadolinium-enhanced MRI of the cartilage, is almost equivalent to doing a diagnostic arthroscopy. So this has to be used. Currently, the T2 mapping as well as intermediate fat saturation use, all this give a great detail. If you look at this coronal image, you can clearly see the lack of cartilage in the medial femoral condyle. It's a TFSC and fat saturation. When you look at the intermediate weighted images, you can see on the lateral sagittal view typically lost cartilage in that area. And also in the sagittal view, in the similar fat saturation, you can see. If you're a sports surgeon, it is a very essential aspect to know how to read an MRI. That makes your life very easy than just going to the report. When you're grading the lesions, again here, grade 1 lesions where you see increased signal intensity on the lateral facet of the patella. In the grade 2, you can see almost 50%, less than 50% of the cartilage is gone. In grade 3, you can see clearly a bit of striation going into the subchondral area with more than 50% cartilage got lost. And in grade 4, you can see complete loss of cartilage down to the subchondral bone. You can see
good afternoon to everybody. I'm Dr. Raju, presenting on bone losses. At the outset, I want to thank the organizers who have given me an opportunity to present my work. And coming to the topic, bone losses in distal femur, they come in various packages. In first, you can see there is a simple bone loss, whereas then as we go ahead, there is complexity is increasing, and when it comes to this case, there is associated patellar injuries, and patellar injuries, mind you, they will have lot of problems in getting the knee ridge. So every bone loss has to be individualized in this pretext. And here, this is one. So, this is one such case where there is an intercondylar bone loss, which is very difficult to identify pre-operatively, whereas intraoperatively one has to be very much prepared to have harvest some bone graft. The consent should be very much in that cases, especially when we are suspecting one. And the last case you can think, there is a supracondylar bone loss associated with intercondylar comminution and a proximal tibia and a patellar fractures. So maximally these are the injuries which have a very poor outcome. Coming to how to evaluate these bone losses. There are these two radiographs belong to the same patient. The initial radiograph is without any traction, without any anesthesia, whereas the second radiograph is with traction and under anesthesia. That is extremely important to quantify the bone losses, because patients will be thinking something else. He'll come with a simple supracondylar fracture as if he thinks. But the complexity of the situation will be known only when we take the patient under anesthesia, and then we quantify the quantum of bone loss, because the amount of bone loss is proportional to the outcome. Here one has to be prepared to take X-rays under anesthesia to know the amount of bone loss, and thereby we can plan the fixation or the reconstruction properly. So a word about volumetric analysis. Why this is important? Because we have done about 30 odd cases, and what we have found is it is very important to restore the quantum of bone losses. Just putting a fibula or putting a couple of fibulae or adding some amount of iliac crest bone graft simply is not going to work. One has to know how much the bone is lost in that. People have worked on this concept, considering distal femur as a barrel, like a conical or a cylindrical structure, and then they have calculated the amount of bone losses. Here in our series, what we have found is, in general, the length of bone lost distal femur is about 140 ml. 8 cm of fibula is lost, and 8 cm of lost fibula quantifies to 140 ml of bone losses. When we have such a huge bone loss is there, about 120 to 140 ml of bone is lost, we have to reconstruct at least 2/3 to have a sound biological reconstruction. That is what our aim should be there. And here we know that the anterior iliac crest yields only 30 cc of bone, whereas posterior iliac crest yields about 30 to 35 cc. And a simple single 8 cm of fibula will yield up to 15 cc of bone. So nowhere we are matching the quantum of bone loss and the quantum of reconstruction. And the basis of any robust surgery which will enable us to go for knee range will be at least 2/3 of the bone should be replaced. So what are our goals? The goal should be realistic. The patient should have a pain-free knee joint. It should be infection-free, because all these cases of bone losses are grade 2 or a grade 3 injuries. They are compound injuries, and we are planning some sort of an internal fixation. So the chances of wound infection are very high, and the patient should be deformity-free. Unless we reconstruct both the columns, the medial and the lateral column, the patient is not going to get a
to deliver reduction techniques in comminuted intra-articular distal femoral fractures.
So after the elaborate technique of loss of distal femur and proximal tibia also, just I'll speak a little bit on the techniques of trips union also. Out of this, varus small union is the most common deformity. Whether to treat conservative or operative, no, there is no question. The operative treatment is required for most of the fractures. Conservative, yes, there is. When the patient is not fit medically or undisplaced fracture, that's very rare to see nowadays. And whatever the fracture pattern, there are certain principles need to be followed. The first thing is reduction. Second thing is providing absolute or relative stability. These two things will come in the same fracture, in the distal femur, because at certain area you require absolute stability, at certain area you require relative stability also. And at the same time, so many fragments will be there, you need to deal with the comminution, you need to preserve the biology of the fracture. So preserve the biology of blood supply, and whatever you do the fixation, you make the patient mobile or movement to be given. That is the idea of any fracture principle that to be followed, that should not be neglected. Coming to the distal femur, there is a unique anatomy. It is not a straightforward bone. If you see, the medial flank varies 25 degrees, the lateral flank 10 degrees. And from trochlear, lateral to medial is 10 degrees. These are important landmarks to be considered where you want to put the screw and get a better grip. So you can't direct the screws whatever direction also. There are certain directions where you need to get hold of the opposite fragment also. So these are important things to be considered, because distal femur, the joint line to be considered, and intercondylar notch also. You can't put the screws across these things, you need to spare. So for a planning, you need to understand what are the deforming forces, the top quadriceps and the gastrocnemius, which might shorten the fracture. We need to neutralize, and same point, adductor forces, gastrocnemius, and these tend to deviate the fracture from to the varus malleus. So you need to understand the fracture. To understand more than X-ray, nowadays we are dependent on the CT scans. Not for every fracture, if you feel the comminution is there or articular surface damage is there, yes, CT has a role. Unlike proximal tibia, where the CT has a major role when compared to the distal femur, because where in the distal femur we can visualize the articular surface. In proximal tibia, we need to do indirect techniques to reduce the articular surface. So never forget to see the pulse. These are common. Vascular damage may occur at any point of time because of the sharpness of the fragment, even while reducing out also. So always check your pulse before and after surgery. Though the limited options for us, the plates, nowadays you see the first generation locking plates, now we get a variable angle. These are more important for today's life in periprosthetic fractures, where you can direct the screws in different. Bridge plating may be required in some fractures, the medial side. So the aim is restoration of articular surface. That's the more important thing we need to deal with. Stable fixation and length restoration. This is also important. We need to get the kinematic axis or functional axis of the limb. So alignment and rotational, axial rotation is also very important, that way we need to see the linea aspera is restored or not, so that we can prevent the rotational deformity of the fracture pattern. In distal femur plating, the start from positioning, this is important step that everyone should follow. You need to check personally so that you can sweep your C under your table. There's no obstruction in that while operating, and proper flexion of the fragment, placement of the niche also is required. Why? So approach wise, some fractures demand extensive approach, some fractures is simple. So mostly spiral fractures, if you can able to reduce with less effort, you can do a MIPO. But most of the fractures requires an extensive approach. Swashbuckler or lateral approach, these are the common approaches generally we'll deal with. Swashbuckler, already previous incision is there, or any, if we are dealing with periprosthetic fracture, we need to extend the same incisions, or too much comminution where you need to approach both medial and lateral also. So swashbuckler is the idea. So medial approach separately or lateral depends upon the fracture pattern, where you require to plate again on the medial side, you might need to approach on the medial side. So coming to the fracture, remove the hematoma, feel the fracture fragments, understand direction is the must to get the success of the fracture, and stability and stiffness of the plate need to be understand whether we are giving a relative stability or great stability. Thank you.
Thank you. To my professor who is sitting in the front row, and my teachers who taught me everything, and my seniors, colleagues. And I wish you all a happy Doctor's Day today. Trochanteric fracture is the reduction. If you don't get a good reduction, you will end up in a mal entry or a false entry, which results in mal reduction, and the problem starts from there, which collapses in varus and retroversion, and gradually either the nail or plate device will fail during a course of time. Why this is called as salute fracture? The subtrochanteric area is highly concentrated and a stress concentrated area because of a change in anatomical structures, like a wider intertrochanteric region becomes narrowed as a shaft at that junction, and this very high large muscles, strong muscles will take origin and some take insertion at that point, which results in, when there is a fracture, it results in a deforming force which causes a specific displacing force which causes the proximal fragment go into abduction, flexion and external rotation. And this attitude, remember, it looks like a saluting soldier where his shoulder is abducted, elbow is flexed and the hand is external rotated. That's the reason it's called as saluting fracture. Next one. So we'll go through biomechanics around the subtrochanteric region. The most important thing which I want to stress today is the nailing techniques of subtrochanteric fractures, which is paramount for good outcome and complications, and finally conclusion. The next slide, please. The learning objectives for subtrochanteric fracture today we focus on mainly on how to understand the deforming forces in the proximal femur, and we also discuss about the review and discuss the common displacement patterns in proximal femur fractures, and also understand the common problems faced during nailing of subtrochanteric fracture. We also learn how to perform various closed reduction surface techniques. If not successful, we can go in and do a minimally invasive reduction techniques. But if the reduction is still difficult, then we can go in and do open reduction, better than giving a accepted mal reduction and associated complications. And also the tips and tricks in nailing of problematic fractures around the proximal femur. When we talk about the anatomical and biomechanical constraints about the proximal femur, if we see the intertrochanteric region is very much widened and slowly it will narrows into a stronger cortical bone, and the cortical bone will heals very slowly because of less blood circulation, and it tends to fracture with combination whenever there is a fracture. And this area is under great stress concentration, and the stress may be about more than 1200 lbs per inch square due to deforming forces of long muscles and high mechanical stresses. When you nail this kind of fractures, the nail will cause, because of wider intertrochanteric region, the nail will face instability, and when we plate it, it tends to collapse in varus and make the plate device to fail and break over a period of time. Why nailing? We are discussing there is instability when we nail in the intertrochanteric wider region. In spite of that, why we have to nail it? There is a study of biomechanical analysis of 4 types of internal fixation in subtrochanteric fracture medals using a DHS, DCS and condylar blade plate and intramedullary devices. Out of these 4 devices, the nail being the mechanical advantage of centrally placed, it will have certain advantages. That is the reason still we use a nail for this kind of fractures. As we know, the liver arm, when the forces acting on a fracture site, the intramedullary device will resist the forces and stresses falling on the fracture site, and that is the reason it will have a favorable outcome. And in subtrochanteric fracture, there is a medial combination and the lateral wall will collapse, and this will result in failure in both medially and laterally. They need only 1-inch incision, and most of the time you may complete this procedure through the cervical screw incision before you put or ream the cervical screws instead of going for a new incision. Next slide, please. This is one more case of, this is the same case of postoperative period after PFNA 1, and that is the follow-up case showing the union. Next slide. Next slide, please. This is one more case example, reduction done with K-wires. Next slide. K-wires and shank pins, reduction is maintained, and a post-operative X-ray showing the results with long recon nails. Next slide. And this is There is a small K-wire which is done in a minimally invasive fashion with a device like reduction clamp, which I will show you. I'm going to show you that it is indigenously developed. Next slide. Next slide. This is the result. One more case. Next slide. Please skip this. Skip this case also. Last 2 slides. Next slide, please. Faster. This is one more. Next slide, please. Next slide. The same technique. Next slide. This is where we can use. Next slide. A shanch pin and a reduction clamp. Faster. This will use a reduction clamp to make the femur in a good alignment with the valgus reduction, and the clamp will be there till the nail enters into the distal fragment. Next slide. Next slide, please. This is one more case, small reduction in the sagittal plane, corrected by a bone hook and a crocodile clamp, a serrated bone clamp, and after reduction, this is the result after 6 months. And such wires and cables, other reduction tools like wires and cables, where these will be done through a small keyhole incision. They are biological, reduction tools, not open reduction. A small incision. They maintain the, blood circulation. And there is a study conducted. There are many confusions like wiring causes necrosis of the bone, but there are so many studies conducted, and postoperatively these wires will cause necrosis and infection, but not actually, because there are a lot of anastomosis around the femur. And in periprosthetic fracture, the hip surgeons, they do 4 or 5 wires contiguously without any problem. So putting 2 or 3 wires is not a big problem in a biological manner. This is a reduction clamp, a reduction clamp through which you...
It is first of all, I want to thank the organizing team, Dr. Ramkumar and Dr. Lakshminarayana and all his colleagues, giving such opportunity for me to do this. Second one, just few seconds to memorize my sweet days. 40 years back, I entered here as assistant professor and worked under Dr. Elmanda Reddy, Dr. Raghuram, Dr. Satyanamurthy, and Venkatrao are my senior colleagues. They showed all the affection like their younger brother. I cannot forget 1.5 years of academic and other happy social events. With that, I would like to start my talk. After robust technological brainstorm from my 5 speakers, I am going to talk a little bit later on, that is total hip replacement. Role of total hip replacement in intracapsular fracture neck of the femur. Of course, we know available treatment options like internal fixation, hemiarthroplasty, unipolar, bipolar, and total hip. But the decision when to do when, that is very important. Here I will be going to talk more about age. The age is a very, very peculiar and undefinable thing, because chronological age is different from physiological age. So chronologically, one may be 70 years, but physiologically may be 50 years. In the same way, vice versa also can occur. So we have to see each and every patient, his activity, his occupation, so many things, and decide about which treatment modality we are going to give. That is the age. I will be giving next slide what are the different modalities to be given. Next comes the fracture pattern, which is very important. All the fractures cannot be fixed. I don't think that all my previous speakers told fixation. I am talking something replacement, not that way. I also, first option is always fix the intracapsular fracture. In a situations where I am going to tell, we have to go for a replacement. Again in the replacement, hemi and total. So a little bit controversy. Probably some questions will be there at the end of the discussion for me. So I will be making a little bit brief in my talk. Then bone quality is very important. If it is osteoporosis, we have to decide whether cemented or cementless depending upon the bone quality. Of course, pre-existing OA-related diseases of the hip like rheumatoid and ankylosing spondylitis, so many. However, in my heading they have given normal acetabulum. Any young person can ask me, why are you doing total hips or why are you replacing acetabulum? I am afraid to answer that. But I hope I can answer at least 70% of that question. Then patient activity is already told. Comorbidity is also very important. If the patient is having some end-stage diseases like either malignancy or nephrological problem or some other metabolic diseases, probably replacement may be the best choice. And also certain pathological fractures like tumors occurring at the neck of the femur and metabolic diseases like hyperparathyroidism, something like that, we have to take them, and sometimes replacement may be the answer. I already told you, the age factor, before 50 years, these are all just, don't take it that dogmatically. Suppose a person comes at 50, do fixation, 51, do replacement, is not correct. I already told you, we have to see the patient as a whole. Coming to the under 50 years, either displaced or undisplaced, fixation is the best option. We have to try for fixation only. Either fibular graft, trochanteric corrective osteotomy, anything, we have to go for fixation. 50 to 65 is a little bit sensitive or delicate age. Here we have to decide between fixation or THR. Probably if the fixation is not suitable, go for THR rather than hemiarthroplasty. Because hemiarthroplasty, most of the times it will give up 10 years. That 50 years man may have life for another 20-25 years. There hemiarthroplasty may go to some other problems like protrusion into the acetabulum and into THR. Of course, above 70 years, if he is an active, robust person, go for THR. If he is having not such and he is having so many comorbidities, better to go for hemiarthroplasty. Here I want to make a very humble thing. I am not condemning hemiarthroplasty also here. Because I have seen in my hands and also my seniors in NIMS, 20 years follow-up of just hemiarthroplasty, doing very well, squatting, walking, refuse to even take X-ray. So these are all different individuals, different systems. But what is today, in 2022, what is to be done for a active, where reconstruction of the neck is not possible, probably total lip is the answer. Then, of course, what are the correct indications for THR in neck of the femur? There are some definite indications. One is displaced subcapital fracture above 60 years, where even during operation theatre we are not able to get the reduction. In that situation, probably THR we have to keep. What we will do is we will keep ready for both fixation and THR. Depending upon the situation, we will go for it. That is one option. Next, intracapsular fracture, unsuitable for reduction or primary fixation, like severe posterior combination of the neck. Then fracture neck femur with head of the femur. Head is gone, so where to fix? In the same way, sometimes the head will get dislocated outside. I have seen the head is lying in the iliac fossa or somewhere outside. In that situation also, probably AVN chances are more. Better to go for a total hip. And IC fracture neck femur in the hip joint, which has undergone radiotherapy, where the potentiality for the healing is very less. In that situation also, better to go for a total hip. In the same way, nowadays with COVID and also steroid treatment, AVN is very common. In those patients, if the IC fracture neck femur comes, probably if the AVN is proved by MRI, go for a total hip rather than doing again fixation, because it is how you are going for AVN. With these clear-cut indications, next slide please. What are the technical considerations in the total hip? Number one, osteoporosis is one we have to consider, especially at the age of 60 or above. Just if you do the reaming, just like in osteoarthritis, suddenly you may get the cancerous bone. Even if you do membrane, if you do further, you may get into the pelvis also. We should be very quiet and we should a lot of patience and keep the reamer in reaming mode, not in a drilling mode. That's a very important point. Then ream very gently. That is very important. And during reduction of the tile or vaginal, when you are doing reduction of the hip joint, very cautious to avoid fracture shaft of the femur. Second one, normal anatomy. In my experience, at least 40 to 50% of the fracture neck femurs, the acetabulum is not rounded, not hemispherical. It will be shallow, probably 50 degrees of inclination. I am taking the normal acetabular anatomy. So we should keep it in mind. Probably reaming vertically down to the acetabular, true acetabular fossa, then from there going to different reaming sizes is very important. Otherwise, you may keep the cup vertical and chances of dislocation may be there. So we have to see that anatomy and we have to keep that in mind. Then here the fracture has occurred in a bone, in a joint which is normal. So we should not disturb the normal joint. My thing is, don't cut the gluteus maximus. Usually in osteoarthritis, other conditions where shortening is there, where the whole joint is contracted, there you have to do all these releases. Here I don't do much gluteus medius release. In the same way, capsular release. Inferior capsule has to be released sometimes in osteoarthritis or high-riding greater trochanter. But in IC fracture neck femur, it is not advisable. I will release the capsule very little. And piriformis is a very muscle, very important in this tendon. This is something like a lighthouse of the joint. Usually in an obese patient, I would like to remove. But very thin patient, especially younger ages, I won't touch much. Preservation of the piriformis gives stability of the joint and avoid dislocations. Especially the dislocations rates are more described in IC fracture neck femur tot lips because of over release of these structures. So I will avoid those structures very much. Of course, tight closure of the posterior capsule and exnotators is very important, and post-operative rehabilitation also very important. Cemented and uncemented options I will select depending upon the osteoporosis. Especially on acetabular side, I will go for a cementless only. Whereas in femoral side, if it is very osteoporotic, I will go for cemented one. Then of course, lift liners, other things I will be telling in my next slides. Here another one point which I have not mentioned in my slide is the limb length discrepancy. It has to be avoided. How to avoid? In osteoarthritis, other conditions where you will dislocate, we can measure the center of the head and very nicely we can know. Here that possibility is not there. One small tip which I want to tell you is, center of the trial head should be few millimeters, 2 to 3 millimeters or 4 millimeters above the center of the retrochanter. If you do like that, and also clinically in the trial reduction, if there is no limb discrepancy, we can easily do it. Probably in robo we can do a better job that gives a correct idea in the navigation and robo. Probably end of this Sunday we are having that talks, you can know about them. Of course, coming to the lipid liner. Probably in a fracture neck of the femur, I would like to go for a lipid liner because that lip, that red arrow is showing a lip, which will avoid, at least give some stability to the joint. So always we use like this lipid liners if possible. But there is a lot of controversy whether to use lip liner or not. That is a different matter. But in IC fracture neck femur, where little bit joint is supple or little bit loose, better to go for a lip liner. Then constraint liner. Sometimes recurrent dislocations can occur, especially in IC fracture neck femur with neurological problems like polio or some other neurological weaknesses, some hemiparesis like that conditions where abduction power is less than 3, grade 3. In the situations, constraint liner also we have to keep it in mind. That particular line, small metal ring, will go into the head, and finally that will go along with the insert to the metal cup so that the dislocation will not occur. Next slide. Next, third one is a dual mobility cup. The indications are same thing like that I told you, where this dual mobility cup we have to use whenever there is a neurological problems or abductor weakness. Sometimes injury can occur to abductors also. In the situations, to compensate the hip stabilizing force, we have to use the dual mobility cup. In the dual mobility cup, it is something like that. One acetabular cell will be there, which will be fixed to the bone, either just hammering it or with the help of screws. Then one liner will be going on it. Then the femoral head, which is available either ceramic or metal, it will be fixed with a special instrument into the poly insert, and these things will be reduced. So there will be practically 3 surfaces. This is a modular dual mobility cup. There is also one more anatomical dual mobility cup. This is anatomical modular. Previous one I have showed is the modular dual mobility. Of course, the same diagram. Next slide, please. This is also like that. We will reduce and put it. So advantages of PHR: better pain relief, better function outcome, lower reoperation rate, better walking. These all are good. And patient, if you tell very clearly, they will opt for tot lip only because fixation and again. So that's all depends upon the patient surgeon counseling. And theoretically, if you ask me, probably fixation may be good for a young person, but at the same time, we have to give these options. There are certain disadvantages also after tot lip. Number one, dislocations, periprosthetic